Guys, after subscribing to this channel, please make sure that you also press the bell icon so that no notification, no new video of mine, any educational video, is missed by anybody.
Let's begin with our lecture tonight, which is on labor, dystocia, and induction of labor. I welcome once everyone in the class, and I hope it's going to be an interactive session. Let's start with the normal labor. Okay. So usually what happens in labor? One is the latent phase, when the patient really comes to you, and the most, what do I say, harassing of all is the latent state, and everybody is like, we as gynecologists, we've been groomed to take every stage seriously, and we take, unfortunately, the latent state very, very seriously. Even some patients have very low threshold of pain, so they keep coming to us, it's paining a lot, it's paining a lot. But actually, this is the time when you should just let her be. Okay, don't have to do anything. Let it be. It's not necessary that she stays in the hospital. She can go back as well, but she should be told about the red flag symptoms. Okay, and what are the red flag symptoms, everyone? Come on, quickly tell me. What are the red flag symptoms? Yes, Shante, your name is coming up. Sujata, Umesh. Yes, Umesh, I'd like to hear from. Come on, Umesh. Tell me, what are the red flag symptoms? For example, a patient comes to you and she's one finger dilated, like happens with most of them. And her contractions are, mild kind of contractions. And she's just one finger dilated, and 30-40% of cervix, which happens at most of the cases when they come to you in labor. So what do you think we'll do if suppose I'm sending her back home, or I'm going to admit her? What should I tell the patient? Okay, counseling part I'll tell you. So it's going to take time. Your labor has started. It's going to take time. You need a lot of patience, and you need a lot of hydration, moving about, and let the pain grow. Once you're in active labor, we will take over. But till that time, you have to be patient with the pain. We will give you analgesics if required, but you'll have to be hearing the pain and take deep breaths, right? But if she wants to go back, yes, you can go back home, but you have to be told certain red flag symptoms based on which you will come back. And yeah, you are writing down bleeding starts. Yes. What else? Leaking starts. Very good. And if the pain increases, yes, if you feel pressure down below, right? As the pain increases, you will have to report back. That means you're going in active labor. So the latent phase usually in the primary is around 20 hours, in multi it's 14 hours. It's very long, correct? Then starts the active phase, and now I'm giving you 5 centimeters as the active phase because as per the latest labor care guide, now it has taken up 5 centimeters as the benchmark. It was 4 centimeters before, and now it's 5 centimeters. Even if you write 4, nobody will say anything to you. But the latest is 5 centimeters. So that's the new limit for active phase of labor. So there is rapid dilatation, rapid descent, a lot of, dynamics changes, and lots of things happen. Fetal heart can suddenly go down, leaking membranes, membranes can suddenly leak, and rupture and cord prolapse can take place. A rupture can take, anything can happen during this point in time. So here you have to be very, very watchful. Correct? So partograph plotting, labor care guide plotting, oxytocin, yes, no, ARM if it's not done already, then all these things have to be managed. Then you have descent and expulsion ongoing. So descent keeps going in, and then expulsion, this is against the second stage of labor. You have to be very, very watchful. Okay, so full dilatation and delivery of fetus, here you have to be watchful for one thing. If the epidural is given in primary gravitas, you can give her 3 hours, not more than that. I'm talking about the second stage. Wait, I'll just write down. This is the second stage here. You see this 2 mark. This was first stage latent, first stage active, second stage, and the third stage. So second stage may, if epidural is given to a primary gravity, you can give her 3 hours. If epidural is not given, you will wait only for 2 hours. For multi-gravitas, the epidural is given, you give her 2 hours. If it's not given, you will not wait for more than 1 hour. You have to intervene there. And the third stage is the one where you're anticipating PPH, bleeding. You need to have good uterine contractions, complete expulsion of the placenta along with the membranes, and patient to stabilize. This is what you want. It should be less than 30 minutes. And then, of course, immediate puerperium, where basically your aim is to stabilize the patient. So hemodynamic stabilization. You have, patient vitals to be checked, urine output to be seen, episiotomy to be checked again. All these things you have to make sure. Okay, so this is normal labor going on. And who will quickly give me the funda for complete normal labor stages? Okay, right from it. How do I call the mechanism of labor? Yes. How will you give me the funda of mechanism of labor? How many of you know about this funda first of all? or whether you've like kind of made a funda for this. The stages of mechanism of labor. Yes. I'll have my coffee. In the meanwhile, I need that funda here, or I need you people to respond. Yeah. What is the different mechanism of the stages of mechanism of labor? What happens first, then? What happens first? Okay, I'll start with the first one. Engagement happens first, right? Then what? Very good, Devashri. This is what I wanted to hear. It's fine. It saved my day so many times, believe me. Sometimes, even in front of you guys, I keep remembering in my mind these kind of fundas. I share sometimes, I ask you sometimes, but these fundas are always there in my mind because when I'm speaking so fast. If I don't remember the fundas, I might fumble, okay, right in front of the camera. So yes, absolutely right. Zainab, have they added you? Are you with a different name, beta? Zainab, I don't remember adding you. So you're a mega course package owner, or are you entering with a different name, or we knew different name from you? Because it's not showing here. Zainab, could you please let me know? Okay. Now moving on. So this was normal labor. Now the mechanism of labor. Okay. So you are right, absolutely everybody. But I'm going to give more marks to Deepa Shri because she has given the funda which I also depend upon. It's Ed Fickery actually. Ed Fickery because I remember putting crown also, crowning as well. So Ed means engagement. D means descent. Ed then Fic. F-I-C. Flexion, internal rotation, crowning. Fickery means E extension, restitution, external rotation, and then again an E expulsion. Okay, so ed fickery, that means engagement, descent, flexion, internal rotation, crowning, extension, restitution, external rotation, and expulsion. Correct? Now let's go one by. Engagement means what? When the largest diameter crosses the pelvis. Correct? Jitu, please handle this. Okay? I know that there is a lot of commotion going on. I don't know how people are entering this group. We'll have to make it little inaccessible now because when these people enter the class, it becomes very difficult for me to handle. Maybe there are some students who enter with a different name and with different names they're registered. So please make sure that you just check these people out if you feel that there is no record of their this thing purchase. Please make sure. Okay. Yeah, guys, coming back. So engagement means the leading AP diameter of the head enters the pelvic plane. That's one. Descent means continuous downward movement, and with every descent, there is ongoing flexion. So reducing the present diameter. How many of you have seen my lectures on mechanism of labor? Because they're available on the YouTube and they're also there in my practical group. So obviously you people are preparing for theory, you must have not taken my practical group, but people who have mega package, see that is the advantage of mega package. People who have my mega package can quickly go and see tonight itself my entire range of labor, in which I have taught you normal labor, normal mechanism of labor, labor in breech, labor in occipital posterior position, in brow presentation. Obviously there's nothing there. Then what do you do in phase presentation, what is the mechanism of everything I've taught you with demo Buddha pelvis. Okay, so that particular thing I would want you to like kind of re-revise, because tonight we are doing the normal labor. So with descent, there's ongoing flexion of the head, which reduces the presenting diameter, and the best diameter kind of by corkscrew movements, it goes inside. Then internal rotation takes place at the level of inlet, the level of what do we call that plane? Least dimensions, plane of least dimensions, right? So there, that is where your internal rotation takes place, and it rotates to 90 degrees to lie anteriorly. The occiput comes right under the pubic symphysis, and then there is crowning with extension. So once there is, the head comes out, it comes out with extension, not with flexion. Correct? Then there is restitution, because there was inside there was a torque, it kind of realigns with the shoulders, and then the shoulders move. So there is an external rotation, and then finally there is expulsion of the baby. Yes, no, what, guys? You remember this? Everyone is with me so far? Am I too fast for this? Because this is MBBS concept, guys. Okay? Everyone clear? Yes. Great. Only Swati is clear? This is normal labor. Okay, where is my star Namrita tonight? So she's not there. So come on, you guys become the stars tonight, isn't it? Zainab, again, please, can you please message me separately your receipt of payment for this group? Beta, because we can't find your records. Just be, kind enough for us, save our difficulty. Just send me a personal message, Zainab, and share your receipt. Because I can't see your name there, and your name here is very different. One person who has, 2 people have left. What happened? Anyways, coming back. Now, certain pelvic diameters, which are very, very important. I'll give you just in one minute. So there is inlet, then there is cavity, and then there is outlet. Okay, what most important diameters are anteroposterior as well as transverse diameters. So just remember this thing very, very clear. The inlet is very simple. It's 11, 12, 13. That's how it goes. And when you're talking about anteroposterior diameter, it's usually the true conjugate, diagonal conjugate, obstetrical conjugate. That also you should know. But here we are not sitting to discuss diameters. I'm just telling you in a nutshell, because we're talking about normal labor and normal fetal positions. So I'm just giving you a brief input. Remember, 11, 12, 13. That means 11 is anteroposterior diameter, 12 is oblique diameter, and 13 is the transverse diameter of the inlet. When it comes to mid pelvis, the cavity, mostly all the diameters are similar. It's around 10, 10.5. But here, we've measured as 10.5 is the interspinous diameter, and sagittal curve diameter is around 11.5, which nobody actually asks. Okay, they usually know that the mid cavity is almost round, and the diameters over there are almost similar, which is around 10.5. Coming to outlet, the anteroposterior is huge, very large, around 13 centimeters, and the transverse is around 11. Okay, so by ischial diameter is around 11 centimeters, and the transverse, the anteroposterior diameter is almost 13 centimeters, which is measured in between coccyx to symphysis. Correct? Moving on. Then what about the fetal skull diameters? So you know what is a suboccipito-brygmatic position? Suboccipito-brygmatic position, that means complete flexion. Suboccipito-frontal means slight deflection. And occipito-frontal means completely deflexed head. See? Well flexed, partial flexion, deflexed head. So 9.5, 10, and 11.5. Or you can remember 9.5, 10.5, 11.5. That is also fine. Then coming to mento-vertical, which is brow. Mento-vertical, it's got no mechanism of labor. You have to take this patient up for cesarean section. It is 13.5. Then face. That means I'm talking about submento-brygmatic. This is around 9.5 centimeters, and there is a mechanism of labor possible provided it's mento-anterior. Mento-posterior, no mechanism of labor. And everything is there in the lectures when you go to the practicals. Engaging diameter, around 9.5 centimeters for biparietal and around 8 for bitemporal. Okay, this is not asked. What is asked is mostly this. So suboccipito-brygmatic, suboccipito-frontal, occipito-frontal. Mento vertical, submento pragmatic. These are the 5 diameters which are asked in the fetal skull. That's all.